Welcome, everyone. This is our 13th webinar on topics that you have chosen that pertain to financing, in particular primary healthcare in low and middle income countries. So today, we're talking about whether and how to develop health financing strategies in low and middle income countries. We know that many of our countries have already developed health financing strategies or are in the process of developing health financing strategies. So we thought that it would be a really good idea to put this on our agenda and to have a conversation addressing 4 specific topics. The first is, what is it? What is a health financing strategy? So that's the first question we'll try to answer today. Then we'll talk about why should we bother developing health financing strategies, particularly because we know that these exercises can be very heavy on the technical level, on the resource level, both financial and human resources. So it's a big exercise. Why should we bother doing it? Then we'll talk about how to go about it. And finally, we'll just ask the question, is it worth going about this exercise in our respective countries? Because we know that at its best, a health financing strategy will provide a really useful guidance towards achieving the ambition of universal health coverage. But at its worst, it can be just yet another report that accumulates dust on someone's desk or on someone's shelf. So how can we avoid that and make sure that health financing strategies are a success? I am incredibly happy to be accompanied in this journey by an esteemed set of panelists whom I will introduce as they speak. But as you can see here, our panelists represent the WHO and, very importantly, 3 countries that have struggled or have attempted to develop health financing strategies. So we'll hear from Ethiopia, from Mauritania, and from Sao Tome and Principe. So without further ado, let me start with our first question, which is, what is a health financing strategy? And what do we know with our 20 plus years experience of developing such policies across our countries? What do we know about the process of developing a strategy? To help us and guide us in this explanation, we're very lucky to have Dr. Serge Mayaka with us. So Serge is going to be sharing with us the approach that is recommended by the WHO in developing strategies. And Serge, you're going to talk to us not only about the content of what a strategy should be, but also the ideal process of how to develop such a strategy. And you will talk to us about both the technical aspects and the political aspects. Serge is a health financing expert at the WHO, a P4H, Partners for Health, P4H focal point in DRC. Serge teaches health policy and health financing at the University of Kinshasa. He's also a medical doctor and has a PhD in public health. Serge, you will be speaking in French, but your slides will be in English. And Serge, over to you. You have 15 minutes to guide us through the recommendations of the WHO.
Merci beaucoup, Nouria. Je vais passer donc à la présentation sur comment développer, élaborer une stratégie nationale.
Well, without further ado, I'm going to move on to the presentation, how to develop a national health financing strategy relative to a number of guidelines stipulated by the WHO. It is very important to first and foremost define what is a health financing strategy specifically. Now, we can develop a health financing strategy in terms of the guidelines of the WHO, and this step by step in order to reach universal health coverage. So there can be a vision document and there can be an operational document or several operational documents, not just a statement of principle, not simply an action plan, a technical action plan, but also a strategic document that ties the vision, the political choices, as well as the implementation aspects. And this makes it possible to organize or structure the whole landscape of health financing, and especially with respect to a number of reforms that are implemented in the health sector, and of course with a number of other actors and stakeholders. Now, health financing strategies are developed according to a rationale, a structured rationale. First of all, there is a section that defines the background diagnostics and the objectives. In that section, we are going to frame the macroeconomic context, the institutional context, the organizational context. We are going to identify the performance problems and challenges, and also formulate specific objectives relating to these performance objectives. So gradually, we are going to move towards the second section. That section has to do with strategic interventions. So we're going to propose concrete reforms, for instance, as well as political tools and instruments to deal with and troubleshoot the performance challenges that have been faced. And this should allow us and help us reach the objectives that we have set out for ourselves. And then third, the section that has to do with the conditions of implementation conditions, governance, for instance, monitoring and evaluation, M&E, and capacity building. All these elements, all these items put together will make it possible for us to define a realistic pathway, and especially as we move towards the universal health coverage. So background diagnostics and objectives. That section allows us to frame the context, to situate the global context within which the health financing strategies are implemented. So there are going to be a number of institutional, organizational, macroeconomic elements that are present, that exist at a certain point in time, and recalling all the various items that have to do with health financing, the normative framework as well, in such a way that we may avail ourselves a foundation of a basis that will allow us to better understand the diagnostics that will be carried out later on. This will make it possible for us to identify the most important performance problems in health financing, as well as the underlying costs. So at this level, it is very important to mention that developing a health financing strategy has to obviously help us, well, requires that we call a number of things into question. And of course, knowledge is important, data analysis and data, in order to feed into the diagnostic aspects related to the strategies that are going to be developed. So an evaluation matrix is a very useful and important tool that will allow us to move towards an appropriate diagnostic. And then this will allow us to respond to the problems that have been identified during the diagnostic process. Second structure, the second major section, this has to do with a number of strategic interventions. Strategic interventions, what are they? They are the interventions that will allow us to steer our actions and to have these concrete actions that will allow us to move towards these objectives to reach them. And of course, a number of reforms in health financing to start to move gradually towards universal health coverage. Now, obviously, with respect to the interventions and strategic interventions, we have to rely on concrete evidence, on analysis, on reports, on evaluation reports, studies, research, and lessons drawn at the regional level or at the international level, basing ourselves on those lessons that we have drawn. And in diagnostics processes, should there be an evaluation report with a progress report, it can be also very, very useful as concrete evidence, especially with respect to the strategic interventions that are going to be developed.
Voilà. Dia suivante encore. Alors, parmi les interventions stratégiques, ces interventions stratégiques, elles peuvent être.
Now, with respect to these various interventions, strategic interventions ultimately can be structured taking into account all the various thrusts and activities in health financing. For instance, we can have resource mobilization in that sector, in that area. We also need to identify the specific interventions that will increase availability, the sustainability of resources, for instance, that are used in health financing, and anything that has to do with resources, public resources, national resources, domestic resources, anything having to do with transition issues, having to do with health financing and the technical partners, in order to gradually reduce dependency vis-à-vis these partners. So budgeting, all those various interventions that make it possible to improve, mobilize more resources. So with respect to, for instance, the purchasing of services, we can identify those interventions that will allow us to be as strategic as possible in terms of purchasing and how we can be as efficient as possible with respect to those mechanisms that will be the most useful mechanisms in order to have appropriate purchasing. So we have to identify specific strategic interventions.
The next section has to do with implementation with respect to governance and capacity building. And it's important that in order to have national strategy that would be implemented in a sustainable way, that we have a clear and inclusive governance. This is something that would allow the institutional and inclusive mechanisms to be put in place. But we also need to put in place a follow-up system, a monitoring and evaluation system that will allow us to follow the implementation of the strategy, to measure the progress of the implementation and the methods, to see how the strategy is working, and this with specific indicators linked to the strategy. But it's also important to invest in a continuous way in capacity building. And this capacity building touches on human, institutional, informational capacities, which will help the implementation and the capacity building to ensure sustainability. So everything that I have mentioned has to do with a structuring method, and a method that is progressive. On a practical level, what does this mean? What is important to really notice? First of all, we need a strong political engagement so that our process is credible. We need a political engagement and a commitment. The government needs to help support the responsibility of this policy. And this responsibility needs to include a steering committee, multi-sectoral committee with a clear mandate and a clear timeline. This steering committee needs to include high-level decision makers, but it will not be able to do the day-to-day operations, which means that there will need a technical group, working group, that will be looking at under the authority of the steering committee, that will be charged with the technical preparation of the strategy. And it's also important to have a large and inclusive commitment by members of the parliament, local authorities, health professionals, the AMA, the Nurses Association, civil society, private sector, insurance sector, and we need the largest commitment from the largest number of actors to guarantee a consensus moving forward and a mobilization. And of course, additional knowledge, if it's available, must be used in the most optimal way. And this must help the various modules and increase knowledge. And it will be essential also to continue exchanging with different stakeholders, different actors, so that in the end, we can get a political validation on a national level at the highest levels of government possible. The national financing strategy must be an instrument for change. It must transform the various strategic orientation in tangible change, in concrete change. And in order to do so, we need to establish the diagnosis, the performance issues, the objectives that will be measurable and specify to look at performance. And we need to also align with the objectives of universal health coverage. This will entail a change of behavior amongst various actors and improving performance indicators. We need to include in this document, and this document must be an instrument that can be used and applied. And the strategic instruments must target the reforms for health strategy financing so that we can go forward institutionally. And this document would allow us to achieve targeted reforms, to reduce inefficiencies within the health financing sector, and meet our objectives. The document will be all the more credible that it is based on concrete instruments. And what are those? Well, it is aligning the strategies of the national health authorities and the national health objectives. They need to be married with the national budget and the objectives and the governance. So we need to have coordination and piloting methods so that the strategy can be followed and can be addressing any conflicts that might come about. So we need, as we mentioned, a monitoring and evaluation. And we need to look at all of these various interventions throughout the year. And I'm going to end here. We will need some directives that are clear, that will align all of the partners for a roadmap with regards to financing actions, and especially when there are diverging issues. This way, we can ensure that the national financing strategy will be something we can act on. And that is really what I can say with regards to the framework of health financing. Thank you, Serge. Your presentation was extremely interesting. It was very relevant.
So as Serge has said, we know a number of things. We have learned lessons, and we now have some normative approach as to how to go about developing a health financing strategy. Nevertheless, theory is is great, but we really need to think about how this is implemented in countries. What are the challenges that we are facing when we try to implement such an approach? To do this, we're going to be supported, as I say, by a fantastic team of practitioners in their respective countries. So I will introduce you all, and then I will turn to you with the questions. Let me firstly introduce Hugo Silva. Hugo is coordinator for health system strengthening in Sao Tome and Principe. Hugo leads the development of all national health strategic documents in the country, including the newly developed health financing strategy. We are also joined by Dr. Ali Cheibani Sheikh Ahmed from Mauritania. Dr. Ali is Inspector General of Health at the Ministry of Health of Mauritania. He has been involved in health system strengthening in the country for the past 30 years at both operational and strategic levels, and has led the development of the, at least for now, dormant health financing strategy of the country. And we've had the pleasure of cooperating in the development of this policy. And finally, I'm delighted to introduce Dr. Abebe Alebachew Asfa. Dr. Abebe works as a health economist in Ethiopia, and actually for a very long time, Abebe, you were referred to as the health economist of Ethiopia. You have 38 years of experience in health strategic planning and policy, health system review and financing in Ethiopia and in many other countries. And Abebe, you were instrumental in the development of the previous health financing strategy, as well as the current health financing strategy in the country. So let me start with the first question, which we're grappling with is, and I'll start with you, Abebe. Why did Ethiopia decide to develop a health financing strategy? And did it coincide with a particular political window of opportunity, and were you trying to answer specific technical challenges?
Thank you very much, Nouria, for giving me this opportunity. I think the first healthcare financing strategy in Ethiopia was really initiated as part of the overall government effort to really bring what we call social sector reforms. It was really laid at higher level by the social sector of the Prime Minister's office. And the government is really coming up with new, for example, education policy, health policy. We are now implementing health financing for 27 years. And they also introduce what we call swaps, the sector-wide approach in terms of bringing development partners into one plan, one budget, one report, and HSDP, Health Sector Development Program, was also initiated at that time. So as part of that, in Ethiopian context, we were implementing socialist policy as part of the Derg regime, and free care is one of our really motives, and we have failed, and we know what really that has really brought in terms of quality and access. So the high-level government politicians wanted to come with new kinds of, increasing access, also mobilizing resources. So health sector was one of the participants, but the lead was at the higher level, and the health financing strategy was developed in 1998. And the main objective was really the first one is mobilizing resources. And in that instance, we really want to mobilize resources from government by strengthening one plan, one budget, one report at district, regional, and federal level, because we have what we call a devolved system where each level of government allocates resources to government. So the health sector has to develop the capacity to build budgeting and advocacy. We also come up with what we call the basic requirement was really, a gap was really, commodities at the facility level. So we really introduce what is called user fees for commodities, not only for other things, but to finance commodities. And we build the capacity of the facilities to really have a revenue retention at their level. And to do so, to protect those, there is a need also to protect the poor in terms of establishing the waiver system, the subsidy for CBHI, and enhancing the autonomy of the facility to use their own resources. So those are the major, really, objectives. So we try to really mobilize resources, but most of the things when you prioritize, we said we have to finance, government has to finance exempted services that are high impact intervention free of care, but resources were not able to do it. So we're not able to do that. So we need to come up with what we call new domestic resource mobilizations that can complement external resources in terms of what do you call innovative financing. We need to scale up CBHI and SHI to move to UHC. So those really requires different political commitments. So we again went into what we call revision of the second healthcare financing strategy, and we have now a second financing strategy approved over the last 2-3 years.
Thank you so much, Abebe. So very clearly, your strategies, the first and the second, were trying to address technical challenges that you were having around financing in the country. And you talk about there was clearly a window of political opportunity.
Yes.
Thank you, Abebe. Hugo, je me tourne vers vous maintenant. Donc, je ne sais pas si vous avez entendu que l'Éthiopie a donc opté pour cette stratégie.
Hugo, I should like to give you the floor now. I don't know if you heard this, Hugo. Ethiopia adopted this strategy for a number of reasons, but technical reasons and technical needs that existed, but also because there was a specific opportunity that presented itself from the political standpoint. Could you share with us the reasons for which Sao Tome and Principe decided to develop a specific health financing strategy? Hello, everyone. Thank you very much, Nouria, for giving me the floor, and thank you very much for this opportunity that you've given me to speak here. I'm sorry, I'm going to speak French. As you well know, Sao Tome and Principe is a Portuguese-speaking country, but it's also a good opportunity for me, for instance, to speak French a little bit from time to time, and I've decided to speak French. Within this framework, within this context, the political realities. I'm going to speak from the technical and political standpoint, both, and those two contexts are the motivating factors. That is what has motivated us to develop a health financing strategy. In Sao Tome and Principe, it is a state strategy where the objective is to have a sort of control of the health financing strategy, and especially involving sound governance, and with a number of fundamental obligations to provide health services, primary health services, and strengthening, bolstering a number of actions and their own legitimacy, national sovereignty to be strengthened. So, of course, the economic difficulties in this country and a number of political requirements came up externally and internally. And there is a political dynamic. There are always changes, and from the political standpoint, this is why, because of these changes, we have to guarantee a certain continuity, especially with respect to primary health services provided to the population. And the challenges, the difficulties are numerous. But I'm going to focus on 3 or 4 main items. Catastrophic health expenditure, for instance, with extremely high costs, external health financing, and the revision of work with multilateral and bilateral partners, of course, and subsidies, the Global Fund, Gavi, for instance, co-financing by the health ministry, of course, as an example. Third, really work towards veritable universal health coverage, guaranteeing access, an equitable access to health services. From the financial standpoint, health services based on, first of all, based on primary health care services. Fourth, the resilience of the health system. So the objective is to make the system as robust as possible, able to respond to economic crises or other types of crises, vis-à-vis climate change, for instance. How do you respond? That strategy has to reflect a certain commitment for efficiency, equity, justice, especially in financing at a high level, but also with a certain level of. Thank you, Hugo. It's not just a technical question or issue. There is, of course, the political aspect, but there is, of course, a technical aspect that comes into play when we are moving towards universal health coverage. So this is, there are a number of aspects and factors that come into play. Thank you very much, Hugo. This is a very important point that you just made there. There's the political aspect, and you talked about the legitimacy of the state. That's one of the reasons why you developed that strategy. Dr. Cheibani, I'm turning to you now. You heard what Ethiopia said and what Tome and Principe said. In just a few words, is this also one of the reasons? Did you choose the same approach because of the same factors, or did you actually develop a very different strategy? Hello, everyone. Yes, indeed. The reasons which were evoked now also contribute to our own why. But I would say that our process began in 2017. And at that time, we had a strategy or policy that was focused on a main objective, reaching universal health coverage. And based on that decision, there was a paradigm shift because the scaffolding of the health system was based much more on supply rather than on demand, and very much based on the population. So a number of interventions, but minimal interventions. Now, with this new approach, and especially wanting to make this accessible for all, from the geographical standpoint and other standpoints, we had to really focus on the demand side of things. And Dr. Cheibani, sorry, we lost you for a moment there. There was a gap. I was saying that from that time on, we decided to place that challenge or that objective at the very highest level, at the presidential level. So that would be part and parcel of the political agenda. So we carried out our own analysis, and we saw that our health financing, there were a number of difficulties, especially in resource mobilization. $15 per person, whereas it should have been 46, or it was 46, or should have been $46 relative to the same countries at the same level. 31%, which represented 1.3% of the GDP. So we wanted to bring this to the very highest level, and political and development and technical partners also supported us. There were a number of difficulties in pooling resources, pooling financing for strategic procurement, and there were many actions that had to be aligned, so there had to be some consistency, and primary health services were at a certain rate, whereas hospital services were at 78%. So it was really important to reposition things, especially primary health services, with respect to that entire context. And so there were a number of difficulties in public financing. So our the development of our health plan had to also fix universal health coverage as a strategic goal. And in order to move towards this universal health coverage, it had been recommended that there be a strategy that be developed in health financing. So since 2017 to 2020, between 2017 and 2020, we started getting some support from a high-level WHO mission and focusing on the main challenges and difficulties that we were confronted with in moving towards a universal health coverage. Thank you very much, Dr. Cheibani. And I've listened to you. I'm glad that you were able to come back and that we heard you again. Now, I'm going to ask you to improvise a little bit now because time is moving very fast. And questions 2 and 3 that I wanted to ask you, I'm going to group them together. So overall, you explained that there were a number of technical and political reasons that came into play that had an influence on the fact that you developed a health financing strategy. But I wanted to ask you to explain the development process more specifically. But now I'm going to ask you to not only focus on the process briefly and highlighting both technical and political issues that you had to deal with and how did you proceed. And what are the lessons that you drew from that experience? When you have 100 participants from different countries, what are the lessons that you would like to share with that you've learned and that you would like to share with other participants? Dr. Cheibani, and for the others, of course, that are online. Well, the process, we first and foremost decided to make the most of this analysis of the situation, of the context. And in our country, populations are dispersed over the entire territory. And so we decided to use a performance-based system and make the most of that, and mapping our resources, and then a number of actions that were carried out in order for us to have more visibility vis-à-vis the future and a better ability to forecast the future. So from that standpoint, we started to organize a number of workshops, first of all in June 2022, where we had our friends from Burkina Faso. They accompanied us in order to analyze our own performance and how we were aligning our actions towards the future in performance-based financing, and of course, after that, organizing a budget. And then for the initiation of the strategy, that was in February 2022, and those were the first bases, and multidisciplinary, a number of sectors were invited, any sector that would be involved in health services, and a number of ministries, line ministries were involved as well. And so those were the very bases of our strategy. And this is how we initiated our strategy. And then we reached a consensus in June 2023 that made the consensus possible. And we tried to make the most of the effort that had been deployed in December. And in December 2023, we had reached the UHC. So that was the process, step by step. And we identified a number of strategic objectives at that point. Strategic objectives were identified at that point to ensure resource mobilization and to reach the 15% required by Abuja, and especially utilization of resources for financial protection, improving resource mobilization in the primary health services provided to the population. So this is still underway, and strengthening underlying functions, especially public finance management, through the dialogue that we have in the budget process.
That was our process. And of course, we were hindered by the pandemic, but we had a number of studies that were able to be validated publicly. There was also a political transition in 2024 that slowed us in our implementation of strategies that would give us the synergy necessary to align with governmental policies. But we were able to build towards our health programs, because if we build them correctly, then we can look at the challenges related to health financing and include them or the solutions in our program. So we were able to include this in our health strategies for the 2026 calendar. Thank you, Dr. Cheibani. It's a process that took a lot of time. We also understand that it's a process that included a number of participants with a lot of technical support. I think you even used the progress matrix. But if the strategy is not ready at a particular time, maybe we missed something. Hugo, we're going to you in Sao Tome. You heard about these program in Mauritania. Do you have something that you could tell us about the process and whether or not the lessons that Mauritania has learned could be applied to Sao Tome and Principe, or do you have other lessons that you might be able to share? We learned a great deal of lessons similar to my colleague. With regards to the processes, we had some 10 years with the preceding system, but we started in earnest a national health system evaluation, which helped us determine the scope of the mission. This evaluation gave us the necessary elements to draft the health strategy on a national level and national plans for health development. But prior to that, we had to develop the stratification, the social definitions, and all of this in collaboration with Social Security and the SDG Fund. Then we were invited to set forth the matrix for the health financial with Geneva. And this would allow us to put together the national strategic plan with health financing. And I think it's important to underline this because the process as a whole was developed by an interministerial team. We had the Ministry of Health involved, but we also had an important support on the part of the Ministry of Health and the Ministry of Economics. This is very important to note because they were involved as part of the process from the leadership standpoint. And we learned several lessons, a couple of lessons in particular. And this has to do with the fact that everyone needs to be involved with the processes. No one can be left aside. And just as Ali mentioned, and Serge Mayaka mentioned, all of the actors must be involved, whether they're technicians, in the health ministers, all of the different ministries must be involved in the health sector. The various partners, organized civil society, including political parties. And that is essential. The documents should also be drafted by a national work team, a kind of task force that would include an international expert that could guide the processes, include the technical aspects. And why do we talk about a national team? Because we are the ones who know the weaker elements or the stronger elements in our country, and we can make the difference. International experts do not know all of these details, all these aspects, and there has to be the national team as in the forefront who has all of this information. It's the ones who know what are the main resources. Thank you so much for these resources.
We're running out of time, but we'll have plenty of time for questions and answers in a second. But Abebe, we've heard it's very important to have all the actors around the table. It's very important to have the national team leading this. It's a process that takes time. And it's a process that is needs to answer a particular political window of opportunity. I'm not going to ask you to describe the process of developing the strategy in Ethiopia. Rather, I'm going to ask you, you've heard these lessons from the other countries. What do you think about this? Does it relate to the lessons that you would like to share from Ethiopia to the audience today?
Yes, I really liked the best practices and lessons learned shared, and I also try to communicate the same thing. In terms of one of the major things in terms of designing and implementing, healthcare financing strategy is, for me, political engagement and commitment at higher level is very critical. I have been working in many countries in health financing, and most of the documents are really on the shelf because they are more technically driven than political engagement. In the Ethiopian context, what I can probably explain is, although we developed through higher political commitment initially to implement the healthcare financing strategy, the Ministry of Finance came up with a new PFM plan that says every resource should be transferred to the Ministry of Finance. So all the initiatives that was planned in the healthcare financing strategy was thrown out. We have to go back to the Prime Minister's level to convince that the amount of resources that are collected at facility and at organization level are insignificant when it comes to fiscal space. So that kind of engagement is critical. So when we design, what we did initially was really the engagement of Ministry of Planning and Economic Development, Ministry of Finance. Ministry of Health was initially as a member, not really a leader. But in the revision process, Ministry of Health was the lead. You are also part of, I think, that evaluation exercise. And we really bring a lot of international experts and local experts to review the performance of the healthcare financing for 17 years. And we learn the best practices and implement, come up with the new initiatives of what should you do better to strengthen that system. But in terms of lessons learning, yes, we have to learn from other countries, but let's really focus contextualizing to our context. I can give you examples. When we developed the first healthcare financing strategy, the MDG was a goal. Everyone was asking us to throw away user fees. We said no. And it helped us to really mobilize that because we come from the free care initially. So it helped us to mobilize the resources at local level and to motivate the establishment of community-based health insurance scheme. So we can now manage. We have designed CBHI in 13 pilots, and we have now 1,300 community-based health insurance districts, and we are covering 60 million people through community-based health insurance for the informal sector. One of the things I would like to share is when you design new initiatives, please pilot, learn from best practice, review the success and challenges, and do scaling up. Don't just do it across the country, even if it looks like good. So one of the lessons is that. The second major lesson that I can share from Ethiopia experience is We are implementing health sector development program and healthcare financing for the last 27 years. And you know what we have? We have what we called annual review meetings. All sector stakeholders. We have what we call annual resource mapping. Every stakeholder has to provide its resources to government, and it has to be reflected and be part of the report. Every stakeholder, every sector strategies has to be reviewed, and everyone has to sit together every year to see the performance of the last year and agree on the next steps for the coming year. We are about to do the 27th annual review in the next 15 days. So what I'm really advising countries is don't have verticalized system of review, have a unified annual review mechanisms to learn and scale up. Third, one of the questions I'm seeing is verticalization and interest. When you design healthcare financing strategy and implement it at a country level, the first priority is country ownership and building capacities, starting from health facility to national level. What kind of capacities in terms of resource mobilization, expenditure management, community engagement, implementing CBHI or SHI is critically important, in addition to mobilizing and using domestic and external resources. So capacity building should be a priority investment. Although we talk about that, usually it's being done by implementing partners. When they go, the systems collapse. So make sure that every design has to be part of the country context. Let me stop. I have a lot of lessons learned, but
I know
I
you
don't want to take.
I know you do, Abebe, but thank you so much. That was a really valuable addition to our discussion today. The need for contextualization, for piloting, from learning from best practice, and the country ownership and building capacity, which also relates to what you were saying, Hugo. So thank you so much, panelists, for sharing your thoughts. We're now opening the floor to questions, and the way that we're organizing this is, Bruno, I will turn to you. You've been monitoring the questions in the box. So over to you, Abebe, Dr. Cheibani, and Hugo. These questions will be for you, as well as for you, most probably, Serge. Bruno, over to you.
Merci Nouria, merci à tous. Et donc, oui, on reçoit Nouria beaucoup de questions et de commentaires.
Thank you. We've had a lot of questions, a lot of comments in the chat, and I'm going to try to summarize some of this. But so, Nouria, we have a question for Serge, maybe? First of all, a number of experts would like to know if there is a canvas of sorts. You spoke about this, Serge, but is there something which would be a national strategy that would be available online, that would be available? And also, how long does this process take? This could be an opinion, but maybe Ali or others could give us some idea of the calendar, how long this process took. There are a lot of questions. Walter, Christian, Antonio have asked questions with regards to the role of the technical and finance partners. Maybe Abebe could address this issue, or Ali or Hugo for that matter. And what is the best way to manage the technical and finance partners involved?
A number of participants also have noted that there's very little attention given to the national strategy. It's as if they felt that ultimately they're just going to do as they wish. And someone also mentioned the fact that there is a certain vulnerability or fragility. I think it was Christian. There was a certain fragility or vulnerability vis-a-vis the technical and financial partners. And of course, the fear that they are going to withdraw, and that would have an impact. And another question raised, that's to the World Bank, which is an important actor, of course, in this context. And I think it would be interesting because within the framework of Mauritania, there is, of course, the support by the World Bank, and a number of strategies were actually supported by the World Bank and funded by the World Bank. So
s'inscrit ou se plie à la stratégie
is
nationale
that
de financement?
something that is positive, or does it have not as much of a positive impact, the support from the World Bank? And perhaps someone
soulève la question, en fait, qui est
was
pertinente, je pense
raising
que
a question which is very relevant, I believe.
le financement du personnel de la santé
The
est un des
funding of
gros
health
enjeux du
personnel
financement de la santé. On
is
sait
one
bien que
of the major
souvent,
challenges
c'est le
in
personnel, c'est les
health
médicaments
financing,
principalement.
staff, of
Et
course,
donc,
but
il
also
soulève la
drugs,
question
medicine.
de quelle
So
place
the question is
donner à
raised,
la rémunération du personnel
what
dans les stratégies nationales
space
de
do we
financement.
give to the
Peut-être une
remuneration
question
of
aussi pour
personnel,
Serge.
of human
Est-ce
resources, and
qu'il y
perhaps
a
for
dans les
Serge,
stratégies nationales de financement une section
within the
qui est
national
consacrée
health
à
financing
l'enjeu du
strategy,
financement
is
du
there
personnel?
something that
Voilà,
has to
j'ai
do
pris
with
cette
the
première volée de
remuneration,
questions. Nouria, je continue la
compensation
suite
of
et
health
je vous laisse
services or health
poser toutes les
personnel?
questions et tu reviens vers moi si vous avez
So
encore du temps.
if you have,
Merci beaucoup.
if there is
Merci
more time,
beaucoup,
you can always
Serge.
come back to me.
Bruno,
Thank you
d'ailleurs.
very much,
Merci beaucoup, Bruno.
Bruno.
Je vais
Thank
peut-être
you.
me tourner vers toi d'abord, Serge.
Well, I'm
si
going
tu
to
veux,
turn
si
to
tu veux
you,
répondre aux
Serge, first,
questions
if you want to
qui ont été
answer
posées, celles
some
qui
of
vous
those
concernent en
questions,
particulier,
some of the
celles
questions that have
d'Anouba.
been raised, especially the one that has to do with the template.
Oui, merci beaucoup, Nouria.
Thank you very much,
Merci pour les questions qui ont été
Nouria.
posées,
Thank you
questions
for
très
the
pertinentes.
different
Donc,
questions, which are
comme je l'ai
indeed very
dit, il y a
relevant. As was
une
said
guide de
already,
référence de l'OMS qui donne
there is a
une
WHO
structure
referential
avec
guide, which
différentes
is sort of
sections pour
structured
justement
with different
rédiger
sections,
une stratégie nationale de financement de la santé.
especially for
Et ça
a
peut être
national
très
health
utile
financing
pour les
strategy,
pays,
and that can be very
comme
useful for a number of
structure en
countries.
termes de raisonnement pour
And it's a
rédiger
structure
la
that can be
stratégie de financement de la
followed with a
santé.
good,
Et je pense que
sound rationale.
ce document de référence, on pourra le
I think that
partager
this reference
dans le chat. Il
document,
est téléchargeable
which has been
facilement
mentioned in the chat,
sur Internet, donc on peut vraiment
is
le suivre. Mais
easily
attention,
accessible and can be, of
ça
course,
donne
followed
une
and
orientation
can be
normative. Ça
useful.
veut dire qu'il
It is
faut,
a
en plus de
normative
cela, contextualiser
document in a way, so it
cette
makes it possible to
structure-là en fonction du
contextualize
contexte du pays,
things
en fonction des
relative
réalités du
to the
pays.
country
Donc,
context, and
l'OMS
things
donne,
can be
peut
adapted
donner une
that
guide de
way.
référence, mais après, il
So
faut
it's a
tenir compte
referential guide,
le pays doit
first
se
of all,
développer une sorte de capacité
and
analytique
then
nationale
it
pour
can
essayer de
allow the country
structurer
to develop
aussi,
its own
contextualiser selon en
national
fonction de notre,
capacity
des réalités auxquelles on est
relative
confronté.
to the
Et donc,
realities that the
voilà ce que je peux
country
dire par rapport
faces
à ça.
and
On pourra même
relative to
ajouter justement le
the
document
national context.
dans le
So
chat.
it can be
Alors,
adapted in this way.
il existe des stratégies de financement
There are
qui circulent. Je pense qu'il faut
financing
plus se rapprocher
strategies
des pays. Là,
that
on est en face
can be very useful and
Dr.
relevant.
Cheibani. Donc, ils ont
Like
sûrement
Dr. Cheibani said,
dans le site du ministère de la Santé, sûrement que ce document a été
at a
posté.
health
Et
ministry
sinon,
level,
on a eu
these
Hugo,
documents
on a
can be very
Hugo, on a
usable as
Abebe.
well,
Donc, sûrement que
Abebe and Hugo
dans le site du ministère de la Santé, ces documents stratégiques ont été
mentioned
également
the
postés.
unit within the health
Le
ministry
Sénégal qui a
where
terminé
the
sa stratégie
such a
nationale de
document
financement de la santé récemment.
would exist.
Donc, je pense qu'en allant dans les sites de ces différents pays, on
I
peut
think, but
facilement retrouver
visiting
les
these
stratégies
different
nationales
countries, we can
de financement
really
de la santé.
have a good
Alors, en termes de
idea
processus,
as
je
to
pourrais
what
peut-être
the
demander aux
national health
collègues
financing
en
strategy
Nice de
specifically is.
répondre pour dire un peu, en effet, ça prend
So
combien de temps,
you can
homologuer, ça prend
also
combien de
have a
temps,
sort of
autoriser, ça prend combien de temps. Donc
checklist
ça, je ne vais pas
to
trop
ask a number of
revenir
questions
dessus.
step by step. How long did
Et
it
je
take, for
terminerai
instance,
par
and so
répondre à
on.
la
And I would
question
end by
du
mentioning
financement
the
du
question
personnel.
of
Effectivement,
staff or human
lorsqu'on
resources
oppose le diagnostic et quand on se rend compte que
financing.
dans le
When you
diagnostic
carry out a
qui est posé,
diagnostic
que
and you
les stratégies de financement de la santé
see
ne
that
tiennent
the
pas réellement en
health
compte les
financing
aspects
strategies don't really take
d'incitation à
into
la performance
account
du personnel et
these
que c'est
aspects of
réellement soulevé comme étant un
staff
problème,
and
alors c'est vrai que dans
incentivizing
les interventions
and
stratégiques
incentives,
qui
then of course
seront
this would have
élaborées
to
par la
be
suite,
developed
qu'on tienne compte
subsequently.
effectivement de la
And
place
where
de
exactly
l'incitation du
is
personnel
a staff or
à la
where are
performance
human
et élaborer
resources placed
des interventions
relative to the
qui,
context, of
en
course,
fonction du
where
contexte,
there
qui
are
seront
as many
les
incentives
plus
as
incitatifs
possible
possibles pour
for
permettre aux prestataires
services,
d'être
human services,
performants. Donc, c'est une question
and
qui est réellement
making it possible
importante
to
et qui nous
reach
permet
the
d'atteindre les objectifs
UHC
de la
objectives.
CSU. Donc,
So
voilà ce que
this is a very important aspect as
je peux
well.
dire. L'enjeu du financement du
The,
personnel est vraiment important. Et
staff
si je le
remuneration.
constate, soulever ça dans la
And of
question,
course, that
dans
can
les
be
aspects
also
diagnostiques et
taken into
traduire
account
ça
in
en
the development
intervention
of the health
stratégique.
financing
Merci.
strategy.
Thank you very much, Serge. You mentioned that the remuneration is a very important aspect of health financing strategies. but you've asked our country colleagues to reply to the process of development. How long did it take you? Abebe, I'm going to turn to you because I'm speaking in English. Can you tell us how long it took you to develop the strategy? Not describe the process, but was it 6 months? Was it 10 years? Firstly, and then can you tell us a little bit more about the role of the international partners, and in particular, maybe the World Bank? How did that go? Was it a process that was pushed by them? Was it a process that was resisted by them? How did this engagement with the whole development of a strategy go?
Thank you very much. I think let me start from the in terms of timing. I think the first one doesn't take too much time because it's highly politically led. But the revision of the second strategy, because we introduced what we call innovative financing as part of new sources of mobilization, it really takes time to really get political commitment. It took around 5 years to really. We have the first strategy, but to get it approved as a revised strategy takes 5 years. That really is too much time. But in terms of engagement, I think we have engaged. But the question that you have, let's separate the two things. The first thing I will call is sector strategy and financing. Sector strategy and financing should be led and owned what we call by a strategy called alignment and harmonization. Government and partners have to really develop together the country strategic plans and prioritize the best ones, develop the costing and the availability of resources, and prioritize it based on what is available. In the Ethiopian context, alignment of partners, be it World Bank or Global Fund or Gavi, has not been a major issue, because they will be engaged right from the very beginning. Even in the previous times, the WHO and global partners did have what they call the IHP compact, where there was what you call joint assessment of national strategies, where partners and government agree together on the draft plan, on the joint financing, the financing element. So working with them to make sure that they own the government's priorities is critical. But if there are interests, countries has to own and lead the process. There are instances, I will tell you, where partners can come with their own initiatives, but they have been told, when we started the health extension program in Ethiopia, nobody was supporting it. And they said, no, doesn't work. We don't want to put our money. And government said, thank you very much. We'll implement it our own way, and you are not going to invest on it. They have to beg to come and really invest on it, because that's one of the effective way of implementation. So country ownership and commitment with effective realization of outcomes is important. But sometimes we talk as the countries. I have been working in many countries, but you don't deliver. In that instance, there is a risk of, what do you call, losing external resources. In the Ethiopian context, the SDG Performance Fund, which is a pooled fund, which is flexible from partners, is one of the drivers of success, because partners have confidence on systems and joint prioritization and joint working. I'm just concluding an impact evaluation of how many, 16 years of the pooled fund in Ethiopia, which is flexible. So the basic really lesson that I'm really sharing is, when you develop your strategic plan, make sure that there is a joint process and ownership of the plan, not only by government alone, but by partners. Make sure that the resources projected from government and partners are realistic. Usually we do wish listing. Usually we do resources that are not available. Let's be conservative, and let's our targets be related to the conservative estimates, and we'll be successful. Thank you.
Thank you very much, Abebe. Dr. Cheibani, je vais me tourner vers vous. Je ne sais pas si vous avez entendu.
Dr. Cheibani, I'm going to turn to you now. Abebe described something that is really a very strong national leadership there. That's what he's describing, with the ability of the government the capacity of the government to say no to donors, and what is acceptable in your context? And could you contrast that with respect to the Mauritanian experience? What is the situation vis-à-vis financial and technical partners on the one hand? And can you tell us how much time it took you to develop the health financing strategy? I should like to begin with how long it took us to develop our strategy. That's the easier question. When we, after having really maximized the studies that have been carried out, and then the validation of the PNDS in 2022, fueling our health strategy. Well, in February 2023 is really when we began, and December 2023 is where the process ended. And it was steered by a team made up of the health ministry, international expertise as well, partners, development partners, and a full commitment by the partners, World Bank and WHO, so as our financial and technical partners. The external financing problem, we had a compact in 2012 to make external financing as good as possible and as effective as possible. Now, an analysis of this compact was carried out, and a number of lessons were drawn, and these were injected into the development of the health financing strategy. So a program budget and alignment of partners will have to be even more stringent in order to be in the sort of more efficient rationale. So that is how I would describe the whole process in our country, in my country. Thank you very much, Doctor. Hugo, did you want to share something with us relative to technical and financial partners? Did you want to share something that's quite different? Or should we move on to the next question? Next question, I think. I just wanted to say that with respect to these processes, generally speaking, they're very dynamic. Granted, in our country, the process was launched about 10 years ago. But we really began in 2019, 2020. At that point, partners, the Global Fund and Gavi, were our partners. And we sort of entered into a transition process at that point. In the case of Gavi, there was the immunization campaign and support towards with respect to the vaccination immunization campaign. So we ask ourselves, how can we, based on the domestic resources that we have, how can we fund ourselves, self-fund our health system? Once we completed the strategic plan, we realized that there was still something missing to really, truly be able to set up and launch the entire process effectively. And especially if we don't really have a full commitment, the full commitment or engagement of the partners, technical and financial partners, I mean. And you really touch upon a very important point, which is the one that has to do with implementation. We've been talking about design and making sure that we avail ourselves of a policy that everyone understands and agrees with. Bruno, I would like to turn to you now. Is there a question that perhaps would tie into this concern that has to do with implementation, or perhaps you would like to focus on something else?
Yes, Nouria, there are a lot of questions with regards to the process to develop the strategy, how we can involve the private sector in particular. That was from Antonio. We also have a question with regards to involving civil society. John asks particularly with regards to the poor populations, not just mid-sized populations. And so how can we ensure that efficiency is taken into account in the development of the strategy? And Tony also says, in a decentralized country, how do we manage this situation? And with regards to implementation, Nouria, you were focusing on this. Perhaps we need to focus what kind of trustee ministry of sorts is going to be responsible for health financing. Oftentimes we see that there are different ministries involved with insurance and so forth. And also, when the strategy is not implemented, what can we do? What are the other tools that we can use for implementation? And I want to insist on Nestor's question, who says that the strategy exists, but when the budgets are written for health and others, then it's no longer taken into account. And the budget we recognize that this health strategy is essential. It has to be integrated in health budgets as a whole. So the question is important. Thank you, Bruno. I'm going to take two of those questions.
Abebe, I will start with you. There's the question around, okay, you've got a strategy, you then implement it. Who is responsible for ensuring that whatever you have agreed in the strategy is actually implemented? You said at the beginning it was the first one was not the Ministry of Health who was in the lead, and then it was the Ministry of Health in the lead. So can you tell us a little bit more about that question of who is responsible for holding everyone to account in implementing what is in the strategy in Ethiopia?
I think when I said it is drafted by higher level, it's only the drafting. In terms of implementation and management, it's the full responsibility of the Ministry of Health, particularly in terms of domestic resource mobilization. But in terms of utilization effectively, it is the role of the Ministry of Finance to oversee its implementation and prioritization. So in terms of implementation, it is the Ministry of Health's responsibility. If you look at the lower level decentralized context, for instance, the facilities are really mobilizing their own resources, and the governance board is responsible to oversee it. And in that governance board, the Bureau of Finance is part of that governance board to oversee it. At district level, again, the Bureau of Finance oversees the allocation and utilization of domestic resources. And the Bureau of Finance also oversees the Ministry of Health's performance in terms of utilizing external resources that comes to that level. So there is a coordination between Bureau of Finance and Ministry of Health in terms of utilizing both domestic and external resources. So that kind of relationship, trust and credibility is critically important. For example, in the Ministry of Health, even in the external resources, in Ethiopian context, we have 3 channels of funding. The first channel is we call it Channel 1, where donors bring resources that are, Channel 1, 2A, which is Channel 2A, brings to Ministry of Health without earmarking. So it is the Ministry of Health's responsibility to really prioritize, allocate, and utilize resources. And there are resources like Global Fund, Gavi, which is Channel 2B, where it's specific health systems. So it has to be managed through government systems, through Ministry of Health. And there is Channel 3, which is outside government system. But through resource mapping and tracking, the Ministry of Health are trying to really make sure that the resources, the interventions that are financed by Channel 3, by USAID in the past, or PEFAR, that are not really part of the government system, are first prioritized as external resources and not financed by other sources of funding. So the concept of one plan and one budget in this case is critical. How can you align different sources of funding to prioritization of the general resource allocation is really critical.
Abebe,
So if
I will cut you there, I'm afraid, because we have very little time. But thank you so much. I think that was very clear.
Dr. Cheibani, really very shortly, when the system is not implemented, what do you do? Hugo, in Sao Tome Principe, the strategy is not implemented yet, if I understand correctly. No, not yet. We have just finished the drafting of the last strategy, but as I mentioned earlier, there is a long road to hoe. And initially, I mentioned that Sao Tome and Principe is a very dynamic country. And it is a very lively democratic system. So what do? We need to change these desires into law so that we can maintain and we can support the process so that tomorrow we know that the implementation will be carried out in the proper way. But I want to go back to something that Serge or Bruno mentioned earlier. It was a question that was related to who is in the leadership position. I think it's an excellent question because in different workshops that we've organized and that we've been part of, in order to develop this, the Ministry of Health needs to be involved. But with regards to implementation, how do we collect the funds? Well, that's the Ministry of Finance. But we should be involved. And this is a discussion that we need to have. We need to put it on the table. But in the meantime, we are trying to develop, and in the case of the EOI, for instance, we need to involve our colleagues and then assess and manage and decide how we use the donor funds. So we've brought up this issue of donors in the case where there are specific laws and the system is clearly set forth by the donors, then we need to use that basket. Thank you, Hugo. Dr. Cheibani, in 30 seconds, no more. Why has the strategy in Mauritania, has it not been implemented? 30 seconds. Well, it's because we have this supra-sectorial system that goes beyond the governmental system. And this is why we have not implemented this. We need to put this on the government's priorities so that we can see the synergy occur with the different ministries. That's the first part. And then secondly, we also need to be able to, through the budgetary discussions before it is ratified legally, we look at the national financing of health and that it be a part of our strategy. Thank you so much, Dr. Cheibani. So as you say, it really goes beyond the responsibility of pure implementation, beyond the document, the excellent document, but goes way beyond health issues. Thank you to one and all for all of your questions. We apologize for not being able to answer all the questions. Before closing, I would like to ask our colleague Raphaël Sequoia, who is...
Pardon, là, je passe à l'anglais, qui est Director of Health Economics at the Ministry of Health, Public Hygiene and UHC in Côte d'Ivoire. Raphael, you're about to embark on the development of a health financing strategy. So we wanted to hear from you what you have heard today. And I'm afraid that you don't have a huge amount of time. So if you can really focus on the lessons that you will take to Côte d'Ivoire in the development of your health financing strategy. But before that, Raphael is embarking on a much more exciting journey, which is being a dad a few days ago. So congratulations on behalf of the hundreds of people, Raphael, for becoming a dad. But let's hear from you about the lessons that you will take to your country. Raphael, over to you.
Bonjour à tous. Je pense qu'il va aller vite, étant
Thank
donné
you
qu'on
so
n'a pas
much,
beaucoup de
Nouria,
temps.
and good day to all.
Mon
We're
intervention va
going
se
to go
situer
fast because the time is short.
premier,
So
essayer de
I really want to
résumer un peu
speak
les
to three
expériences
issues. First of all,
tirées des
I'm
trois
going
expériences
to try
empiriques
to
à travers
sum up some of the
les
key
différentes structures
lessons
d'Afrique
based on the three experiences that
et
have
je
been
vais
shared
aussi
by
aborder les points
Ethiopia,
fondamentaux qui
Mauritania, and
ressortent
Sao
de ces
Tome.
expériences
I'm also going
et qui,
to
selon nous,
speak to
pourraient
some of the
peut-être contribuer
fundamental
à notre
issues
réforme
that
nationale du
I
financement de la
hear
santé.
from
Et
these
enfin, je vais
experiences and
terminer par
what are the
présenter
issues that we
l'approche
have to
et
put
les
in place
ambitions de la Côte
for
d'Ivoire dans le
any
cadre de
national
l'implémentation
reform
ce
of
document de
health
politique
funding.
sur le
And then I'm
financement de la
going
santé.
to talk
Donc,
about the
sans
situation
plus
in Côte
tarder, je pense
d'Ivoire
qu'au
and
niveau
the
de
document and
l'Éthiopie,
its
l'expérience
ambitions that have been set forth for
cette année nous a
financing
montré la
health.
richesse et la transformée
I
grâce à un
hear
système de
that
gratuité
for
de soins
the
mis en place dans nos
last
systèmes de
17 years, you've
promesses
gone
qui a été
from
plus ou moins
free
inefficace et
systems that
sous-financé.
many of
Donc,
our
ça a
countries are
permis de structurer
aware
une
of
stratégie
to
autour de
that was
plusieurs
somewhat
piliers dont la
inefficient as
mobilisation
far as
accrue des
financing
ressources domestiques
to a
à
reform
partir
or of
de tout ce
the
qui est financement
structuring
innovant.
this
Donc,
new
l'introduction
strategy.
aussi de
And this
mécanismes de
has a
partage de
number of
coûts
different
avec une
pillars,
attention
different
particulière sur la
mobilizations of
protection de la
domestic
hausse
resources
grâce à
and
des
innovative
exemptions et à des
financing,
subventions.
the
Bien
introduction
entendu,
of
le
mechanisms to
déploiement
cost
progressif aussi de
sharing
l'assurance
with
maladie
particular
et sociale
emphasis on protecting the
au niveau
poor
du secteur
population,
formel et bien
thanks
encadrement au
to
sein des régimes. Donc, il faut dire que
subsidies, and of course,
cette
how
réforme
these
piloté politiquement
progressive
volontairement
deployment of
permettra
health
certainement
insurance
de
has been paying.
pouvoir
So,
intégrer
of
les
course,
aspects
this
multifactoriels
reform at a higher
à la
level is going to
transposition du
allow
ministère de
us
la
to
Santé
include
et
all
commencer
of
les
the
finances
various
des hôpitaux
multisectoral
régionaux,
aspects,
des pathologies
including
financiers
the
avec
health
l'apport
ministry, the
des
finance
intervenants
ministries,
du
the
financement de la
regional
santé. N'oublions pas que
authorities, the
le
technical and
financement de la
financial
santé, c'est une
partners,
question qui est éminemment
and
politique.
of course,
Donc, il faut s'assurer aussi de
health
défendre ce
financing
leadership
is a
au niveau
political
politique.
issue.
Donc, je pense
So we need to
il y a
have
aussi cette
their
ambition-là de
leadership
couvrir
and their
plus de
support as
60
well.
millions de
I
personnes
think we
à
also
travers
have the
l'assurance
ambition
maladie pour
to cover
s'assurer d'un
over
état de
60
réduire tout ce qui est
million
dépenses
people
pharmaceutiques.
through health
La
insurance,
leçon
and
principale
we
vient de ici,
need
c'est vraiment ce
to
leadership
reduce
fort
anything that has to
pour qu'il
do
puisse
with
vraiment avoir une
catastrophic
implication
spending.
des méthodes de
So
financement.
the
Donc, on a
main
parlé aujourd'hui
lesson
des questions de financement de la
is
santé au niveau
has to
sécuritaire. Il
do
faut
with
aller
the
vers de ces
leadership. We
finances pour
cannot
qu'on puisse
talk
avoir des
about
interlocuteurs, des
health
vecteurs de transfert
financing
dans
in
les
terms of
priorités
just
du
that
secteur de la
sector.
santé au
We
niveau
need
du
to
budget.
look
Les
to
arbitrages
the
sont
Ministry of
souvent en faveur
Finance.
du ministère de la
We need
Santé.
to look at
Au niveau
all
de la
of the
Mauritanie
various
aussi, il faut dire
actors
que
who
on
are
a lancé deux
involved.
défis
And
majeurs,
within
deux défis politiques
Mauritania,
qui plus
I
ou moins
heard
visent à
two
inscrire
main
la
problems,
santé comme une
political
priorité nationale
challenges,
au plus haut niveau
um,
de
per-
l'agenda présidentiel.
and that has to do
C'est
with health
après avoir
being a
fait
national
étape
priority at the
qu'au
highest
niveau
levels
technique, il faut s'assurer
and on
de
the
pouvoir
presidential
adopter une stratégie de
programs
mobilisation
and
des ressources
president's
domestiques
agenda.
qui est
And
suffisante
so
et une
this
mobilisation de
leads
mise en
to
commun
adopting a
qui va
mobilization strategy
faire
for
mention
domestic
de la
resources that would be
coexistence de
sufficient.
plusieurs
And
réformes de
uh,
gratuité qui n'étaient pas
we
harmonisées,
also heard
donc ce qui vient
mention of
fragmenter un
the
peu le
coexistence
système
of
et qui impose
reforms of
d'inefficience. Bien
free
entendu, il faut peut-être
health
de passer à une
that was
recherche
not
stratégique
harmonized with
et
the
aussi
system. So
la définition plus du panier
inefficiencies, of
essentiel de
course,
soins. Faire accès sur
has
les
to
soins de santé
been
primaires,
uh,
c'est
something
vraiment
to
quelque
deal
chose qui
with.
est très important parce
And
qu'il
the
faut savoir quoi
definition of
financer et
these
pourquoi le financer.
health
Donc la
or
Mauritanie
basic
aussi
health, that is
nous a
something that
montré
has to be
qu'ils sont passés, ils ont procédé à une cartographie de l'offre de
focused
soins, donc
on.
à une redéfinition du panier
We
essentiel.
see that you
Ils ont
did a
rédigé aussi une
mapping
partie sur
of the
l'analyse qui a été faite
essential issues, a
concernant
redefinition of
l'approche
the
de
basic
financement basée sur la
issues. You've
performance.
also
Et bien
analyzed of
entendu, ils ont
the
voulu
uh,
capitaliser aussi des résultats
performance-based
de plusieurs
financing,
analyses qui ont été menées,
and
notamment
you
la
wanted
revue
to capitalize on the
internationale de
results of
l'évaluation
various analysis that had been led with regards to health development, a national plan that is. And we've also seen a number of various workshops you mentioned, that all of this going towards the alignment of the objective for health resources with the available needs in the health field.
And in order to reach the objective, and especially with respect to the budgeting process and the allocation process, apportioning the health expenditures, and of course with public health, public expenditure management, that health centers be autonomous and making it possible for these health centers to be resourced at an adequate level. So in the case of Sao Tome and Principe, a different perspective is provided. And of course, the country was very, very dependent on foreign aid. And of course, a very, very heavy burden for households that were facing very high costs. And so the strategy was designed with a number of objectives in mind, to which control the get back to legitimacy of the state and reduce dependency vis-a-vis external funding and aid. And an important point for us was to strengthen equity and to create a more resilient system able to respond to crises, whether they were economic crises or epidemiological crises. So a number of attempts were made and they were aborted, but they were relaunched in 2019 thanks to the support of the World Health Organization. And we had to redefine a number of services within a package. And of course, with the funding of the health sector, there was the framing process also that was important. And of course, the strong involvement by both the Finance Ministry and the Health Ministry, which ultimately both had the same aspiration. So the significance here of total inclusivity is very present. All the actors are stakeholders. They all have to be around the table. And with respect to the financing strategy, all those players have to be present and together, emphasizing national priority in the drafting up of national strategies, because that is where the national context is the most well known. So we can actually list a number of priorities: strong political leadership, significantly strong political leadership, the full commitment of the Finance Ministry, because no sustainable alignment is possible between, it would not be possible between the Health Ministry and the Finance Ministry. Consensus, of course, building consensus and bringing together technical and financial partners, supporting the government, the private sector with corporate social responsibility, of course, and mobilization of resources, and also something that will help us identify needs, especially the populations have identified a number of priorities. So there has to be the full participation of populations as well, and reviewing the strategy, something that was already mentioned a couple of times. And of course, the leadership, strong leadership by the government to strengthen equity and resilience. Now, to come back to the Côte d'Ivoire, we have to say that our country is well engaged in on the path of reform. And for pregnant women and children under the age of 5, we have to ask the question: are all children under 5 years of age and pregnant women do they not have enough resources to be self-sufficient and take control and charge of their own selves? This is why the reform was carried out and initiated. And of course, health coverage and universal health coverage, this is something that we are moving towards gradually. But of course, performance-based financing is the apparatus now, and we have a platform that brings together all the actors that we have already mentioned, working hand in hand with the Prime Ministry and the Cabinet. So a number of significant documents, and this has to be really done at the very highest level so that the line ministries are all together, and in order for us to be able to instruct the various technical ministries so that these are better able to implement, execute these priorities. And so we have this that's going to be done from 2026 to 2035, 10 years. And this will allow us to review the health sector system. And 2 years have already gone by, so we're going to have to be very much up to date and define opportunities and seize the opportunities when they come up. And of course, procurement will have to be very logical, and there has to be a strong rationale. So at health system level, anything that has to do with human resources, infrastructure, maintenance of equipment, medical equipment, training, and so on and so forth, all those aspects have to be taken into account in a health system, a public health system, because there is a relationship between all those various aspects. And of course, placing the population to the very heart of these strategies, at the very heart of our strategies, and at the very first contact level. You have 30 seconds, 30 more seconds. Well, by way of conclusion, very briefly, what I can say is that as a country, as a state, we wish to align the needs of the population, thanks to the available funding, that these documents be translated and that they really be rooted on the budget process, and that we can reach a stage where a number of laws are drafted up and then promulgated and executed, so that we don't have a sort of document that is going to be relegated to the back drawer. That we want to avoid at all costs. Thank you very much, Raphael. These are very relevant reasons, and I'm thinking about a number of countries that are going to be engaged in the same kind of process. Well, we have reached the end of our webinar, and very sorry that we've ended a little bit late. Thank you very much to all the panelists, Dr. Cheibani, Hugo, Serge, Raphael, all of you. Thank you so much. Thank you so much, Abebe. Once again, thank you very much to all of you, to each and every person, to all the panelists and everyone. And we wish you an excellent day or evening. Thank you very much. Goodbye.
Thank you very much and
Farewell.
goodbye.